Bonjour, merci pour l'invitation. Donc aujourd'hui, je vais vous parler.
So, I'm going to talk about how to treat anemia in cancer patients, in particular using IV iron, and more specifically, ferinject, which is the use of which is restricted still. So first, you have to differentiate two types of iron deficiency: absolute iron deficiency, which is defined by no iron storage, no iron stored. So you actually carry out ferritin assays. So it's typically under 20 micrograms per liter in a normal patient, but for cancer patients, it's lower than 100 milligrams per liter. On the other hand, functional iron deficiency, well, in that case, there is iron stored, but iron deficiency is present in erythroid bone marrow. It can be because there's iron sequestration in macrophages. It's what is called anemia of chronic disease. Or it can be that it's because iron requirements are increased and that iron sequestration in macrophages cannot meet the demand. And it's particularly common in patients on EPO therapy. So to illustrate that, here you have the macrophage, red blood cells that actually get really imprisoned by macrophages, and plasma transferrin has a certain capacity to fixate iron, but and it's then fixated on the erythroblasts in the bone marrow so that it can be transferred to hemoglobin, to the red blood cells. In absolute iron deficiency, the red blood cells actually, well, all the iron present in those red blood cells is going to be liberated in the plasma transferrin that is circulating, but because it can't really be fixated, it's actually just liberated and lost and can't be transferred into hemoglobin. In functional iron deficiency, iron release is blocked so that instead of being liberated into transferrin, iron actually remains in FID, and as a result, the liberation of stored iron drops by 20%, and bone marrow will be iron deficient, the same as for absolute iron deficiency, but despite the presence of iron reserves, which is why it is a functional type of iron deficiency. In cancer patients on EPO therapy, functional ID actually results in the fact that iron need increases, and it actually cannot be met by the quantity of iron liberated in plasma transferrin. And since demand exceeds the supply, that causes another type of functional iron deficiency. It can be assessed because transferrin saturation is below 20%. You can also assess it with other parameters. And since there is quite often either absolute iron deficiency or functional iron deficiency in cancer patients, well, cancer patients actually are more susceptible, more prone to developing functional ID. These studies have demonstrated that EPO therapy, and you have a randomization of the different arms, no iron, iron, and IV iron. And actually, the message is that with IV iron, we get more responses. For example, you see the curve here, the evolution in EPO with IV iron or without IV iron, and the hemoglobin is increased thanks to IV iron. And a very important message is that oral iron is hardly any better than no iron at all. So using oral iron supplements actually is completely useless. This is a meta-analysis that actually collated all the randomized studies, 8 randomized studies, and hematopoietic response is 30% higher using IV iron compared to EPO on its own without IV iron. So not only is the response better, but it also makes it possible to reduce the number of perfusions. So EPO on its own can help reduce the number of perfusions, but thanks to IV iron, you can reduce the need for more perfusions compared to EPO on its own. So you have a study here with 2 arms. You have one arm on IV iron, and you see the significant reduction in the need for more perfusions. This is confirmed in 2 meta-analyses, about 23% fewer perfusions needed when patients on EPO also are put on IV iron. The EPO dose necessary to get the response with hemoglobin rate around 12 grams. Well, actually, the EPO dose can be reduced. You have patients that are randomized between IV iron and no IV iron in the other arm. And you see that the dose of EPO necessary to meet the target, the therapeutic target in terms of hemoglobin, is actually lower when you use IV iron compared with the patients without any IV iron. So the total dose of darbepoetin necessary will be significantly lower when you use IV iron on top of EPO, the EPO therapy. And that use of lower doses of EPO will help reduce costs. Why? Because EPO costs are way higher than IV iron costs. You can see in this first study here a comparison of total costs, and you can see that in light blue, the cost in EPO, which is by far the biggest chunk of the costs, and you see the cost of IV iron, and that actually the total costs of EPO plus IV iron is lower than EPO on its own because you can use less EPO. So here you have on the right-hand side EPO costs without IV iron, and the cost of EPO with IV iron, and you see that the iron IV costs are really negligible, and that cost savings in total are about 13% when you add IV iron to EPO. But can we use IV iron alone without any EPO? Well, data are way more limited at that point, and evidence is less conclusive. But all the same, I'd like to present some data. You have those first studies. They are randomized control study of average quality in anemic patients on chemotherapy treatment when they are on IV iron compared to patients with no anemia therapy. Well, the ones on IV iron tend to need fewer perfusions. Let me emphasize again that those studies are on a small scale and of average quality, so it's not conclusive enough. Now, coming to ferinject. First major study was an observational study. That observational study was conducted in Germany for 12 weeks with 600 patients who received at least one dose of ferinject. No other IV iron, at least one dose, but most of the time several doses of ferinject. They're patients with solid tumors, and the overwhelming majority received ferinject without EPO, and the median dose was 1,000 milligrams of iron per patient. You can see that these patients are under a number of therapies because of their cancer. Most of them are on chemotherapy, and a majority of these patients have not received any treatment for their anemia. No perfusions, no EPO, no iron, be it iron or IV or any other treatment. So the majority of patients receive ferinject as a first treatment for anemia. So what are the findings? Where in yellow you have the general population. In light pink you have patients on ferinject plus EPO, and in purple, the patients on ferinject alone. Let me emphasize again that it's not randomized. So it seems that you have a sort of a sharper slope, and you see that we reduce dose when we meet the target, and responses with IV iron seem to be comparable, maybe a little bit better than with EPO, but we need to be careful. Why are patients on some patients on IV iron alone and others on IV iron and EPO? It is not randomized, so to really be handled carefully. Here on this graph, we notice that the lowest the hemoglobin rate, the more efficient ferinject seems to be. You see the pink curve with a low ferritin dose. Patients with a low ferritin dose, low ferritin level, seem to respond even better to ferinject. Only one randomized trial with IV iron alone. It's the last study I'm going to present. It's very limited in its scope. In anemic patients with indolent lymphoid malignancy, they present functional iron deficiency, and they are on chemotherapy. They have not had any other anemia treatment, and they should have serum ferritin level that has not gone up too much. It's been randomized, but as you can see, only 10 patients in each arm. That's not a lot. Either no treatment for anemia or a single dose of ferinject, IV ferric carboxymaltose. Findings, but yet again, let me emphasize that the number of patients is very limited, but the increase in hemoglobin level is significant, about 2 grams, and statistically higher than hemoglobin levels in patients without any IV iron. So limited number of patients, but significant responses, but it cannot make for conclusive evidence. So ferritin levels increase, and saturation levels also, transferrin saturation levels also increase, which makes sense. So by way of conclusion, I would say that for patients on chemotherapy or patients on radiotherapy or no anti-cancer treatment, EPO therapy, well, 1 gram per month, it seems to be efficient to get the patients to a level of about 12 grams. We try to use the lowest possible EPO dose to maintain to still meet the target. There is no justified indication to increase the dose. It doesn't work. Objectives are, of course, to reduce perfusions and enhance quality of life. But despite that, only 2 out of 3 patients respond to EPO. And majority of patients who do not respond are the ones with functional iron deficiency. And this is where IV iron really has a role to play. 2 products are available in Europe: Injectafer or ferinject, depending on countries, and the recommended dose is 1 gram in 30 minutes. So then it transferred to macrophages, which is transferred to plasma, and makes saturation more efficient, and the bone marrow is stimulated by EPO more efficiently, which makes it possible to reduce the dose. So response is faster, response rate is higher, perfusions can be fewer, and we can use a lower dose of EPO. So in conclusion, we have to assess iron status for patients when initial diagnosis occurs, and at least on a monthly basis, once they've been put on anti-anemia treatment. There are 2 possibilities. Either there's an absolute iron deficiency, and ferritin is lower than 100 nanograms per milliliter, or in the case of functional iron deficiency, there are iron reserves, but ferritin is higher than 100 nanograms, and we find that IV iron will help with the saturation and the transferrin saturation, and we find that in a case of functional ID, EPO plus iron IV enhances better responses. Thank you for your attention. Many thanks for this very clear presentation. So in your conclusion, you said that in case of functional iron deficiency, the best way to go is to have EPO plus IV iron, but you also demonstrated there's no data to prove that EPO had an added value if we have EPO plus IV iron. Well, no, I don't think you can say that. The first studies were carried out with EPO, and EPO clearly demonstrated its efficiency in terms of response, increasing hemoglobin levels, fewer perfusions, and quality of life. This has been demonstrated by very large-scale randomized trials. IV iron on top of EPO demonstrated certain efficiency. 8 randomized prospective trials plus a meta-analysis clearly proving that IV iron on top of EPO even makes for even better responses and fewer perfusions. IV iron on its own, the evidence is not conclusive. I showed you 1 study, another study with ferinject, only 20 patients, so it's very limited, and 2 very small randomized trials with iron scores that are fairly poor. So evidence at this point is too limited for any recommendation, but you should recommend it if there is an absolute iron deficiency. If there's absolute iron deficiency, it's a no-brainer. You need to you have to recommend iron IV. But if it's not an absolute iron deficiency, the evidence is not conclusive enough to recommend it.
Thank you very much for that presentation. Can you comment on the safety and tolerability of the intravenous iron?
Okay. Yes. The tolerability is depending on two different types of reaction. First, you have the acute infusional reactions. These are only related to the dose that you give. I will make an exception for dextran, of course, but for the other form, there is an acute infusional toxicity if you do not respect the maximum dose that can be given. Why is it so? Because the different compounds have different speed of metabolization in macrophages. Mm-hmm. For instance, iron dextrans is metabolized very slowly. So once it enters the macrophages, it is releasing its iron very slowly. So there is very little infusional toxicity. The same is true for ferinject. Mm-hmm. It is releasing its iron slowly, so there is limited possibility of infusional toxicity, because infusional toxicity is occurring when you inject a lot of iron. It is digested by macrophages and it is released too massively to plasma transferrin, oversaturate the transferrin, and when transferrin is oversaturated by iron, that's when toxicity occurs. Mm-hmm. So for iron gluconate, the maximum dose, for instance, is 125 milligram. For Venofer, it's 300 to 400 milligram. Mm-hmm. For ferinject, 1 gram. And for iron dextran, it's several grams. So this is infusional toxicity. The second toxicity is the acute allergic reaction. And these reactions are mostly reaction to high molecular weight dextran, which was available in the past. It is no longer available in most European countries. I believe it is still available in the US. So high molecular weight dextran is associated with a relatively high risk of acute allergic anaphylactic reaction. So that's a very specific reaction. Now, for the long-term toxicity, well, I should also mention the possibility of having when you combine IV iron with anthracycline, you have a theoretical risk of increasing cardiac toxicity of anthracycline, because part of the cardiac toxicity of anthracycline is mediated through iron-related mechanism. So there is a theoretical risk there. It has never been proven in clinical studies, but in animals, there is some evidence that this could be when you combine the same day IV iron and an anthracycline. So my personal recommendation is not to infuse IV iron the same day as an anthracycline, but that's not proven in clinical studies so far, but it is proven in animal and in vitro studies.
S'il vous plaît. S'il vous plaît. Oui. Ça marche, non? Oui, oui. So, on sait très bien comment évaluer la...
Well, we know full well how to assess iron deficiency, but in common practice, it's not always well done efficiently. But do we know how to assess EPO's reserves so that we can look at EPO dose in a case of real deficiency, so that we can really reduce costs? Well, in terms of endogenous EPO assessment, of course you can carry out blood tests, but the normal values are the normal values for normal people with no anemia whatsoever. So in anemic patients, it can grow exponentially. So an EPO value that remains at a normal level in an anemic patient is clearly indicative of an endogenous deficiency, but in patients with a deficiency in endogenous EPO seem to respond better than patients with no such deficiency in endogenous EPO. But the difference is not that significant. Yes, with people with low endogenous EPO, the response is better, but we can't really say that that patients with no low endogenous EPO levels will not respond. It is not really significant. It is sort of statistically significant, but it can't really be used in common clinical practice. We can't draw the line where we'll give EPO and we won't give EPO. A normal patient on EPO will respond very well. So I wouldn't actually use assessment of endogenous EPO levels as a guideline. With people with very high EPO levels, well, clearly that would be indicative of the inefficiency of the treatment. So you should not treat. That's the only exception.